Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this dermatology series. In today's dermatology-focused episode, we're tackling psoriasis, a common and chronic inflammatory skin condition. Psoriasis can range from a mild nuisance to a condition that significantly impacts quality of life, making it a vital topic for primary care practice and PANCE preparation. We'll walk through its pathophysiology, clinical presentation, management, and some pearls to remember for practice. Plus, we've got a couple of clinical questions to test your knowledge. Let's dive in. Let's start off with some basic pathophysiology. Historically, psoriasis was viewed as primarily a disease of hyperproliferation. However, it is now known that psoriasis is a complex immune-mediated disease in which T lymphocytes, dendritic cells, and cytokines play a central role. The typical clinical findings of scaling, induration, and erythema are the result of hyperproliferation and abnormal differentiation of the epidermis, inflammatory cell infiltrates, and vascular dilatation. When compared with the normal epidermis, this hyperproliferative state is characterized by increased numbers of epidermal stem cells, increased numbers of cells undergoing DNA synthesis, a shortened cell cycle time for keratinocytes, and a decreased turnover time of the epidermis. Now, it's not just a disease of the skin though. Psoriasis can involve the nails and the joints as well, which we will discuss in a little bit. Next, let's talk about the clinical presentation. The most common subtype is chronic plaque psoriasis. This is characterized by symmetric, well-demarcated, erythematous plaques with overlying thick silvery scale, often on extensor surfaces like the knees and elbows, scalp, and gluteal cleft. Other subtypes are guttate psoriasis, which presents with an abrupt appearance of multiple small psoriatic papules and plaques, often following streptococcal pharyngitis. Third is pustular psoriasis. This subtype can have life-threatening complications. The most severe variant, the von Zumbusch type of generalized pustular psoriasis, presents with the acute onset of widespread erythema, scaling, and sheets of superficial pustules. And lastly, erythrodermic psoriasis. This is an uncommon manifestation that may be acute or chronic. It is characterized by generalized erythema and scaling involving most or all of the body surface area. Affected patients are at high risk for complications related to loss of adequate barrier protection, such as infection and electrolyte abnormalities secondary to fluid loss. Now, like we said a bit ago, psoriasis can also affect the nails, causing pitting, onycholysis, splinter hemorrhages, and subungual hyperkeratosis. And don't forget psoriatic arthritis. Patients can have joint pain, joint stiffness, and back pain. The diagnosis of psoriasis is clinical. Well-demarcated erythematous plaques with silver scale on characteristic locations like the scalp, elbows, and knees often make the diagnosis straightforward. Biopsy is rarely needed but can be helpful in atypical cases. And remember to assess for comorbidities, including metabolic syndrome and joint involvement as part of your evaluation. Now, let's talk about the management. The major treatment modalities for chronic plaque psoriasis include topical therapy, systemic therapy, and phototherapy. The extent of skin involvement plays an important role in treatment selection. For most patients with a limited degree of skin involvement, which would be less than 3 to 5%, topical therapy is the preferred initial mode of therapy, of which topical corticosteroids remain the mainstay of treatment. They alter gene transcription, resulting in anti-inflammatory, anti-proliferative, and immunosuppressive effects. In addition, a topical vitamin D analog can be added on for more effective treatment than topical corticosteroid monotherapy. And for patients with extensive disease or disease in difficult to treat sites, phototherapy or systemic therapy are the recommended. Now, here are a few clinical pearls. Number 1. Psoriasis plaques often have pinpoint bleeding after removal of scale, which is called Auspitz sign. It is a helpful diagnostic clue. Number 2. Presence of the Koebner phenomenon. This is when there is development of skin disease in sites of skin trauma. However, this finding may also occur in other skin diseases, such as lichen planus and vitiligo. And number 3. Screen for psoriatic arthritis. Joint involvement can be subtle and debilitating if untreated. All right, let's practice some questions. Question 1. A 38-year-old man presents to the clinic with a rash to his elbows and knees. He denies systemic symptoms but mentions a strong family history of psoriasis. Exam reveals well-demarcated erythematous plaques with silvery scales to the extensor surfaces of the elbows and knees. Nail pitting is also noted. Which of the following is the next best step in management? Is it A, start oral corticosteroid, B, begin topical corticosteroid and vitamin D analog, C, refer to rheumatology for suspected psoriatic arthritis, or D, initiate systemic biologic therapy? I'll give you a couple of seconds. If you chose B, begin topical corticosteroid and vitamin D analog, you are correct. This presentation is consistent with limited plaque psoriasis. Topical therapy with the topical corticosteroid is the first-line treatment. Question 2. A 50-year-old woman comes to the clinic with a 3-month history of an itchy red rash to her scalp and ears. She denies fever or systemic symptoms. Exam reveals erythematous plaques with silvery scale to the scalp and post-auricular area. No signs of infection are noted. Which of the following is the most likely diagnosis? Is it A, seborrheic dermatitis, B, tinea capitis, C, psoriasis, or D, contact dermatitis? If you chose C, psoriasis, you are correct. Psoriasis frequently affects the scalp and ears. The erythematous plaques with silvery scale are characteristic. Seborrheic dermatitis usually presents with greasy scales, while tinea capitis would likely involve hair loss or broken hairs. Great job! Thank you for joining us on this journey through psoriasis. Whether it's recognizing the dermatologic presentation or knowing when to initiate systemic therapy, you're making a difference in your patients' lives. Don't forget to subscribe and tune in for our next topic in this dermatology series. And, as always, this is the Pro PA Podcast, where future pros in medicine are made. See you next time.